Welcome to Redefining Global Health in the 21st Century. Now, you might notice that we're not sitting in the Bay Area of San Francisco. We're recording this at the Rio AIDS 2026 AIDS Conference. Yes, Mike and I have managed to find our way here, and we're sitting out in a cool part of this beautiful brutalist conference center, Rio Centro. So let's introduce our guest. Mike, hi there.
Hi, Ben. Good to be with you.
So we've spoken about the end of the old order. Mm-hmm. We've spoken about money.
Yeah.
And today we're going to talk about water. Well, water as part of the climate crisis, and what you and Eric propose are the ways forward for global health. Now, you talk about a climate-enhanced syndemic, not a one disaster, a sort of a cascade. What do you mean by that, and how do you see it affecting our work in global health?
So I think, as we articulate in that chapter of the book, every infectious disease that we are currently battling will be exacerbated by climate disruptions. In addition, there's the potential for unknown emerging infectious diseases to have impact globally as a consequence of climate disruptions. And then many non-infectious diseases that we should be attending to in the global health space will get worse. And I think all of that means that in this next era of global health, we really must focus on how we anticipate and mitigate the impacts of climate on health. So the chapter sort of articulates first the impending burden of disease that will unfold as the planet warms up. And then the second half is a set of ideas around how we might think about mitigation from a programmatic point of view, but also from a financial point of view. Yeah.
So it reminds me of a podcast I just did recently under the AIDS 2060 chapeau. And it was with a political guru. I can't call him a political scientist because he's more than that. But Arthur Snell, former British diplomat, who wrote a book called Elemental, just out, looking at the geopolitical impact of climate change. And I wanted to get his sense of what was going on in his mind from the global health perspective. Zero was what he thought was happening. And the bottom line message was, you guys have really got to get your proverbials together.
Yeah, I think that's absolutely true, right? The COP meeting, this is the annual climate meeting of heads of state in Egypt in 2025, was supposed to be focused on health, but I think the sense was that it was a misfire. The opportunity wasn't taken to really highlight the importance of health as an issue that we had to address. I think when you look at all kind of country plans for responding to climate change, hardly any of them have details around what a national adaptation plan for health might look like, let alone a budget for it. It's just not a priority. Yeah.
Well, let's hope it becomes one rapidly. Here we are at the end of July 2026. We've got extraordinary wildfires in Spain and France. Donald Trump is putting sanctions against Canada for its wildfires. Not that there's much they could do about that. And, if what we're saying is that 58% of human pathogens are made worse by climate crisis, at what point does infectious disease control and climate adaptation stop being two different, you mentioned budgets, two different budget lines?
Yeah, I mean, I think that they inevitably require different kinds of investment, but I think should be construed as investments that are addressing the same challenge, right? Yeah, you're right. There will be a substantial increase in infectious disease. I think you quoted the 58 known human pathogens that are going to get worse, or the data already shows are going to get worse. And one of the things that we highlight, which isn't rocket science, is that one of the best ways that healthcare systems can prepare for climate change is just being more resilient. So investing in infrastructure that will allow those health systems to function in spite of climate shocks, be able to detect emerging infectious disease sooner, providing a safety net for those that are most vulnerable. And we start with a case study from Pakistan. In 2022, there was a devastating flood that flooded huge amounts of flat land in Pakistan. And in addition to causing profound population disruption and internal migration, it led to 2.6 million new cases of malaria. There's a fivefold increase in dengue. And at the same time, 20% of all primary care infrastructure in Pakistan was underwater. So the health system was not able to respond accordingly. And I think that sort of highlights that you need to anticipate those threats and prepare your health system to be able to respond. And if you're in a situation where the risk of flooding is really high, then having a health system that can, immediately pivoting to responding to vector-borne diseases or other waterborne diseases would be critical. Yeah,
because and I'm really glad you raised that, because in the description you provided about Pakistan, they had a double whammy, because after that immediate shock, dengue, malaria, and how does not to be too dramatic, a shattered health system then combat? These are perfectly manageable. But in the absence of a functioning or a really hard-hit health system, how do you manage that?
Right. Well, yeah. I mean, I think that's why the dividend of health system strengthening is so important in terms of building that kind of resilience. And I think we give another example, which is a sort of a more positive example of Cyclone Ida in Mozambique, where the cyclone tore through a huge amount of northern Mozambique, caused profound disruption to HIV programs overnight. But because there was an infrastructure of HIV service delivery, because PEPFAR had been there providing services for the previous 2 decades, they were able to respond really quickly and resume programming really quickly. Now that takes resources. It takes a robust health system, and in that setting, it takes a health system that was well funded or reasonably well funded through donor support. And I think that it illustrates where, if you build resilience in the healthcare system, it's possible to respond to these health shocks.
And the Mozambicans relied a lot on PEPFAR's infrastructure, which of course may or may not exist for much longer as they try and find alternative sources of funding. You mentioned Cyclone Ida, and the recovery worked. Why? What is it about the climate health resilience that had been set up that made the difference?
Yeah, well, I don't want to sort of sugarcoat or make it sound like an entirely successful outcome, but where there was resilience, I think it was a function of where there had been investment in the health system over the previous months and years. And specifically investment to ensure that there weren't stockouts, that the information systems ran okay, that there was reliable source of energy, so generators when there wasn't access to electricity, and and then, support for healthcare workers. And all of those things are just sort of usually the nuts and bolts of a functioning healthcare system. So I don't think like climate resilience in the healthcare space is anything other than a well-functioning healthcare system. But in a context where, for example, you don't have a reliable supply of electricity, then maybe resilience means having a backup generator or access to solar panels, for example. Maybe it is a plan for how you will pivot to, relocating services if you're in a low-lying area that is at risk for floods, and having contingency plans in place. Much of that should be routine part of good public health, but isn't. And so the case we're trying to make is that as we think about a climate resilient healthcare system, we just need to be thinking about investing in the health system. And look, I think one of the criticisms of the HIV response over the last 20 years is where it's gone badly. It's been siloed and verticalized. Where I think where there is potential for real climate resilience is where services are integrated, where there's been holistic investment in the health system, and all the building blocks of the healthcare system have been strengthened.
It's really struck me during the course of these discussions about the book that the future for all of these known and unknown health challenges really root themselves in some form of integration and collaboration across the health sector and beyond. And one of the things that really struck me in your description of Ida was the role that the primary care system played, and sort of really as a foundation block for everything that then needed to happen. How would you globalize that, or what would you do to strengthen a primary care system so that it became the center of resilience?
Yeah, it's a great question. I think one of the biggest assets to a resilient health system is having a highly effective community health workforce. That is there on the ground, that knows how to respond to the common disease threats that communities face. And countries that have effectively scaled community health workforces, places like Ethiopia, I think are places where there is that potential for resilience in the face of climate shocks, etc. So yeah, I think one of the most important things that we can do is invest in a community health workforce as a component of that climate resilience.
And that was true for COVID. It was obviously true for HIV. We're seeing it in malaria and TB as well.
Exactly.
So, I'm just sort of trying to think what it might look like for, say, PTSD, which in an environment where there are perhaps repeated climate shocks could become much more of an issue, the whole mental health question.
Yeah, there's some great models out there for empowering community health workers to support mental health. And there's a program that was funded through USAID to Johns Hopkins that did that scaled a really evidence-based intervention that was sort of informed by cognitive behavioral therapy, but basically empowered community health workers to deliver supported mental health services to their communities. So yeah, definitely, I think there is a way of thinking about how many elements of the healthcare service provision that are currently being provided in secondary and tertiary centers could be delivered out in the community.
Bringing us back to Rio, July 2026, how much of this are you seeing in sessions at the conference? Because the vibe here that I'm picking up is one of, and I think you used this, sort of a hardened core of countries, of health service deliverers and providers thinking we really can't rely on the US anymore. We have to do this ourselves with our own funding, our own support. Clearly, community health workers are not cost-free, but they are an affordable way of providing services. Have you seen that in the sessions you've been a part of and the conversations that you've seen? Have you seen that be a part of some of the ideas that are being bubbling up here?
Yeah, I mean, look, I think, right, that the conversations here at Rio are not at all focused on climate, but there is a lot of discourse around how a country is going to maintain their HIV programming as donor funding contracts. And just this morning, I was in a session with Professor Malenga from Zambia, who was making the case for how they needed to scale community-based volunteers in Zambia as part of providing robust care, particularly for vulnerable communities in Zambia. So that's certainly one example. And there has also been discussion in the context of these USG MOUs around how some of that strategic funding that's coming through the MOUs can facilitate or incentivize partner governments to invest in a community health workforce. And then there's been, at the margins, some interesting innovative models that I've seen of how digital solutions might be used to remunerate community health workers in an effective way for performance-based programming. That's pretty cool. I don't know that that's being scaled anywhere, but that kind of solution, I think, could be used very powerfully in the context of a climate shock. You could quickly mobilize, a cadre of community health workers to respond and pay them immediately for the interventions that you could verify by smartphone.
Yeah. And that also speaks to the so-called professionalization of community health workers in terms of their training, in terms of their regular reimbursement. But I guess with something like Cyclone Ida, it's all hands on deck when something like this goes belly up.
Yeah, sure. Yeah.
One of the other things, and it's really a sort of almost a sort of a central organizing idea of the chapter, is this donut model.
Oh, yeah.
Now, could you explain to us what a donut has got to do with global health?
Yeah. Well, maybe I'll back up first. So I am really interested in this idea of donut economics, which was coined by an Oxford economist, Kate Raworth. And her central thesis is that the way we do business globally, the expansive nature of capitalism, the notion that, growth is key to sort of economic vitality, should be reimagined. And so she comes up with this idea of a donut approach to sort of an economic model where countries should really invest their resources not on growth per se, but really on investing at the social foundations of a community, and then investing in things at the sort of ecological margins as really important fiscal goods. So I was interested in that idea and thought, well, maybe this is actually applicable to how we should be thinking about, both how donors and countries invest around climate. If you imagine that the center of the donut is the social foundation of a community, how can you make sure that those that are most vulnerable, those that are most marginalized, are protected against climate shocks? And that might be primarily the responsibility of governments.
Now, is this, sorry for this stupid, facetious question, is this a ring donut or is this a jam-packed donut?
So it would be a ring donut. The central gap is the sort of where they're like ideally the social foundation is that catches those most vulnerable, right? So you strengthen that central ring, and then the margin of the donut is sort of the ecological margins. Thinking about air pollution, thinking about water pollution, thinking about infectious disease threats and surveillance infrastructure that are necessary to respond to climate threats. All of those things, and those things at the sort of the ecological margins are conceivably things where there is most value in high-income countries investing as well as low-income countries, because those are the things that affect all of us.
Yes.
So the center of the donut, as it relates to sort of climate resilience, is the social foundation, which every country should be responsible for. But the ecological margins are things that maybe the high-income countries and donor constituencies would pay most attention to. How do we think about mitigating air pollution?
Yes.
Can we think about better ways of rapidly responding to emerging infectious disease threats? These sort of broader cross-border threats.
Yeah. And again, for the industrialized world, particularly around wildfires, respiratory diseases.
Totally.
Yeah.
Yeah, exactly.
Yeah. So for a country, say like Cameroon, how would you advise it to invest? Where would its priority be? In which part of the donut should it?
Yeah. So for a country like Cameroon, I think that the number one priority should be, how do you close those equity gaps so that those individuals that are at greatest risk for disease generally are being scooped up and cared for by the healthcare system. And that doesn't really matter whether there is an emergent threat or not. I think it comes back to my earlier comment, like that's where I think you need a resilient healthcare system. There are some countries that just don't have the resources even to do that, right? And there are some communities within countries that are not necessarily well protected or cared for by their governments for political and legal and other reasons, right? And so that might be a space where donors come in and say, let's help you to ensure that those particular communities are protected against those exogenous threats. So that's how I imagine it would be in Cameroon, like in many other countries. Yeah.
So this is a conversation at the policy level that we've got to take to COP, to people who are at the highest level, the UN, making decisions about climate strategy. Do you think they are adequately thinking of the health ramifications of climate change, climate crisis?
I don't think heads of state or chancellors or finance ministers are prioritizing health, period.
Yeah.
Certainly not in the context of climate, right? I think that the biggest threats that they perceive are how climate will undermine economic growth and industry, etc. And that's reflected in where countries have developed national action plans, and mitigation strategies for climate. Health is just not part of many of those plans. I think we document the very few countries that have that kind of mitigation plan in place for health.
So a big elephant in the room, or elephant in the warm air here in Rio, it all comes back down to money though, doesn't it?
Yeah.
And you spend some time in the book looking at how you can make the case, or in this chapter, how you make the case to funders, whether it's Ministry of Health, of course, always come towards the bottom of the pecking order. And hopefully climate folks are a bit higher up on the scale. But where money is tight, what do we do?
Yeah. So I think there's two ways of answering the question. Maybe I'll take a digression, if it's okay, and sort of highlight one of the things that we describe in the book is lessons that could be learned from Mia Mottley.
Yeah.
So she is the president of Bermuda.
Yeah.
And has been a really influential leader in the discourse around how low-lying nations are at increased risk for climate threats. Not only are they at increased risk for climate threats, but as she has articulated really clearly, oftentimes they they're at risk for serial threats, and so they ask for concessional loans to respond to a disaster, and then quickly they are hit by another disaster. And so she has championed what became the Bridgetown Initiative.
Yes.
Which is an initiative that sort of makes an argument for how these countries should they should be eligible for a set of financial concessions, including loan forgiveness, just like high-income countries got after World War II.
Right.
And then climate bonds, like an insurance mechanism that they could tap into as necessary. And so I'm not a financial expert, neither is Eric, but we just make the sort of speculative case. Maybe there's a role for something like that is health specific, that is climate related, where countries that are most vulnerable to climate threats could be eligible for climate health bonds. They could tap into that as necessary. They may have to pay into it as well. But look, the other framing of this is that the vast majority of responsibility for where we're at in terms of climate damage, rising temperatures, and all of the other deleterious sequelae of climate change are high-income country responsible. Like, if you look at greenhouse gas emissions over the last 200 years, most of it is coming from the global north. And so what Mia Motley makes the case for is, like, why are we carrying the burden of this and continuing to have to pay the burden where actually it's greenhouse gas consumption and emissions in the northern hemisphere that are driving many of the health sequelae, not just health, but sort of climate sequelae that low-lying countries are most vulnerable to.
Yeah. Well, I think two things come from this. The first is, it seems a way of tying us into the reckoning conversation that still hasn't been completed with colonists and colonized countries, and that those countries, those regions that were responsible for so much of the effects that we're seeing of the climate crisis now, surely they have some additional responsibility. But there's another side to it too. And you talked about low-lying areas. I mean, look at the American coast around the Gulf of Mexico, the Gulf of America, the Gulf of Mexico. And you see states like Alabama, like Florida, that really, Louisiana, that really are at risk of a significant population disruption happening. All it takes is that one typhoon, that one climate shock to hit them, and they too are in the middle of it.
Yeah. No, I think that's what we saw with Hurricane Katrina, right?
Yeah.
It had absolutely devastating impacts. Obviously, the challenge though is that many of the sequelae of a heating planet are not going to happen over one political cycle. We don't even see them sort of evolving over like single decades, right? It's multiple decades of change. And in fact, we recently looked at look to see in a large HIV cohort whether there was an impact of climate change over a 10-year time horizon, and we looked at rainfall and temperatures. And whilst those have increased since the pre-industrial age, they haven't really increased statistically significantly over the last decade.
Right.
And so all of that is to say that I think it's hard to make the case to an individual political leader that investments they make now are that are going to have a dividend in 20 or 30 years time are worth making. It shouldn't be hard. And I think there is a generation, my kids' generation, who really care about this.
Yeah.
And maybe things will change. But historically and currently in the political climate in the US, climate is not a priority. And I think will be found out for that in the future, which sort of raises this whole other question for me. Like, as we think beyond Trump 2.0 and the future of global health, how can we center climate as a key element of what donors invest in and how we think about sustainability? The healthcare industry globally is responsible for like 4.6% of all greenhouse gas emissions. So not a huge amount, but not an insignificant amount. And it's fair to say that, and I don't know this, I'm just speculating, probably 4% of that 4.6 is coming from high income countries in the US. Yeah. But it does make me think that as we think to the future, we should be thinking about how do we do global health more sustainably? How do we, wherever possible, regionalize our manufacturing rather than rely on expensive, global supply chains.
Which ties us in so much to the question of global equity around access to medications and affordability. Yes,
exactly. And then another interesting thing that you and I were talking about off air is that there are actually some really cool new medical tools on the horizon that may have a greenhouse gas dividend that is worth sort of leaning into. And specifically here I'm referring to some of our prevention tools, lenacapavir and cabotegravir, because you have to administer them less frequently. You don't need as many milligrams of the individual drug. And as a consequence, they generate, in terms of the active product ingredients, they generate far less greenhouse gas emissions. So these are things I think we should be thinking about. Not only are these drugs well liked by patients for the most part and seen to be highly efficacious and may lead to better quality of life for individuals who don't need to take a pill every day, they may actually have this really important sustainability dividend.
Yeah, that would be one very good way of folding health into the climate activism movement. So one final question for you. If there's one piece of health infrastructure that you know well, whether it's a clinic, a supply chain, a particular program, if it had to survive a flood, a heat wave, or a massive power outage, do you think it would? What's the one investment that you would make to make sure that it could?
Oh man, that's a good question. Look, I think I go back to what I said before. A really resilient healthcare system is reliant on an effective health workforce, and having a well-paid, well-trained health workforce is going to be key to responding to climate shocks. Clearly, there's more to it than that, but I think that's probably one of the areas where I think there's most value in investing in.
Yeah.
That's not to say that we shouldn't embrace the opportunities of self-care and think about how digital innovation might allow us to, deliver care with less healthcare workers and things like that. But from a climate point of view, having a health workforce that is able to respond effectively to emerging threats, I think is critical. Yeah.
So moving back then to Rio.
Yeah.
Perhaps one of the biggest opportunities for us at these conferences is to network, not so much the seconds, but the sessions, but the people we meet, the people we bump into.
Yeah.
What's been the most surprising networking opportunity you've come across?
I've had many great networking opportunities, very few of them sort of climate related, but after the opening ceremony, I was waiting for my Uber, and obviously there was 1,000 people waiting for Ubers, so I was stuck, and I went to the hotel over there and asked to use the restroom. The public restroom was on the top floor, and I went up to the top floor, and there was a UNAIDS reception going on, UNITAID reception.
UNITAID, that's right. Yeah.
And I went and used the restroom, and I stood in the urinal next to Tedros, the Director General of the WHO. My claim to fame at Rio was that I had a close encounter with the Director General of the WHO, who's a good man by all accounts.
Oh, yes.
Yeah.
Well, I'm afraid we've got to leave it there. But what a way to end it. So look, in the next episode, we're going to look at a world that is fragmenting. We'll ask what's left of the global health movement's authority, and what do we have to do to reclaim it, and build some kind of governance that will work for the future. Mike, thank you very much. It's been a real privilege, and see you next time.
Thanks, Ben. Lovely to be with you.
Lovely. Well, that's it for this episode. Thank you to Dr. Mike Reid, Professor Mike Reid.
No, I'm not a professor. Not yet.
Are you assistant professor?
Associate. Next
professor.
year, if I play my cards right.
Yeah. So thank you to Dr. Mike Reid of UCSF. Thanks also to Eric Aspera, our fearless director and producer from A Shot in the Arm Media. You will not have noticed that during the course of this episode, we were stopped by security and had to justify our reason for being here.
Right.
And finally, a big thanks to you. And look forward to you joining us when we record the next Redefining Global Health in the 21st Century.
Thanks, guys.